Good morning, faculties, my seniors and my colleagues. Dr. Ashish Kharel, and today I'll be talking about the primary neoplasms of the pleura. This is a two-part presentation. In the first part, I'll be focusing on the solitary fibrous tumor and other rare variants of primary pleural neoplasm. And in the second part, I'll be talking about the malignant mesothelioma of the pleura. So, primary tumors of the pleura are very rare diseases, and most of the pleural tumors that are found in our clinical practice are found to be distant metastatic deposits. And anatomically, the pleura consists of a matrix of collagen, elastic fibers, lymphatics, and blood vessels, and which are covered by a single layer of mesothelial cells. And the primary pleural tumors can arise from any of these various types of cells. So, of the primary pleural neoplasms, almost 90% are malignant mesotheliomas. And of the remaining, half of them, that is around 5% of primary tumors, are the solitary fibrous tumors, whereas all other tumor types, they comprise only less than 5% of the primary pleural neoplasms. So, we'll be talking about the malignant mesothelioma in another presentation. Today, I'd like to focus on solitary fibrous tumor. Although this is a rare tumor in itself, we usually encounter it in our clinical practice, and there is one patient even right now in our ward who has this disease. So, SFT is a mesenchymal spindle cell tumor that arises from pleural fibroblasts. It was first reported in literature in 1767 by Lutau, and later definitively by Wagner in 1870. And previously, it was known by various names like benign mesothelioma, pleural fibroma, as it was thought to have arisen from the mesothelial cell itself. But in 2013, the molecular evaluation of around 40 pleural receptors and other receptors from other parts of the body were done, which revealed that there was a fusion of two genes, the NAT2 and STAT6, due to the recurrent inversion of long arm of chromosome 12. And this was the primary driving tumorigenesis in these solitary fibrous tumors. So now it has been definitively proven that solitary fibrous tumors arise due to the fusion of these two genes. And the most common site of solitary fibrous tumor is the pleura, and in the pleura, almost 80% arise from the visceral pleura. So, on clinical presentation, these tumors most commonly occur between the 5th to 7th decade of life, but there are many case reports that have shown these tumors arising in children or even in octogenarians. The male to female ratio seems to be the same, and most of these tumors are so slow growing and asymptomatic. However, they may show rapid growth, and sometimes the tumors are present in huge size, even up to 20 centimeters, displacing the entire pleural space. And such large tumors, they usually present with cough, chest pain, or dyspnea, and in extreme cases, even with stridor. So it has been found that these SFTs also show paraneoplastic syndrome. Of these, two are important. The hypertrophic osteoarthropathy may be present in up to 5 to 25% of these SFTs, whereas hypoglycemia, also known as dose-Potter syndrome, occurs in less than 5% of SFTs. Regarding the risk factors, there have been no identifiable risk factors in these tumors, as obvious positive factors such as smoking and asbestos have not been implicated for the causation of these diseases. So, how does the tumor look in imaging? In CT scan, usually a well-defined, occasionally lobulated mass, up to 40% of SFTs can be seen with a stalk. And with the soft tissue attenuation of harmful units 25 to 40, that displaces rather than invades the surrounding structures. And larger tumors may be associated with heterogeneous enhancement and density, which is related to hemorrhage, necrosis, and areas of cystic degeneration. Lymphatic metastases are rare, but may be identifiable in malignant cases, and up to 40 cases we may identify a vascular pedicle on contrast enhancement. And because of this pedicle, in repeat imaging, there may be tumor mobility resulting in changing the shape or size or location of the tumor. Similarly, in MRI, although the CT scan is the gold standard imaging modality, MRI may be used sometimes, and in MRI, low to intermediate signal intensity on T1 and heterogeneously low intensity on T2, with areas of high T2 weighted intensity where there is hemorrhage, necrosis, cystic degeneration, or where there is increased vascularity, especially in the stomach. So this is a CT scan showing a large left-sided solitary fibrous tumor of the pleura, and in the left side is the X-ray of the same patient, and we can see the heterogeneous pattern of the tumor showing the areas of cystic degeneration and necrosis. So this is another CT scan showing the pulmonary window where the benign solitary fibrous tumor of the pleura can be seen in the right lung field. The tumor is showing an acute angle with the posterior and diaphragmatic parietal pleura. And we can see the characteristic pattern of this tumor is that it is displacing rather than invading the surrounding lung. So this is a picture of the SFT in an MRI. You can see the low signal intensity in the T2 weighted images, and there are several flow voids which represent the vessels. So how do we diagnose these tumors? The definitive diagnosis relies on the pathological analysis of the completely resected surgical specimen, and FNA is usually unreliable for diagnosis of these diseases, and mostly if FNA is done, the diagnosis will come as either non-diagnostic or an unspecified mesenchymal tumor. A needle biopsy, also if there is large tumor with the degeneration or cystic areas, may not show any diagnostic needs. But if you are using an FDG PET to target the hypermetabolic areas, it has been shown that up to 100% of tumors can be identified by the transthoracic needle biopsy. A PET scan has not found to be much useful for diagnosis, but can again be used to identify the hypermetabolic areas or to define whether the tumor is benign or malignant. So in histology, it has been characteristically defined as a patternless pattern of ovoid to spindle cells with variable cellularity in a collagenous stroma with numerous thin-walled branching vessels, also known as the hemangiopericytoma-like vessels. And the classic SFTs are relatively hypocellular, whereas the cellular SFTs have more compact or spindle round cells. And in the benign variety, the mitotic activity is usually low and necrosis is absent, whereas in the malignant ones, there may be a high mitotic activity as determined by the Ki67, and necrosis is usually abundant in these cases. And England et al. Have defined an England's criteria where hypercellularity, nuclear pleomorphism, and extensive areas of necrosis and hemorrhage, and more than 4 matrices per 10 high power field have been shown to diagnose the tumor as a malignancy. So this is the microscopic appearance of a benign STFP with a patternless pattern. Whereas this is the appearance of a malignant SFT, where you can see the increased cellularity with cellular pleomorphism and the mitotic figures. So coming to immunohistopathology, CD34 is the characteristic diagnosis for SFT along with BCL2 expression. And usually, if the tumor is negative for pan-cytokeratin and positive for CD34 and SFT, CD34 and BCL2, then we diagnose this tumor as a solitary fibrous tumor. But in malignant cases, the CD34 may be absent. But what is always true is that there is a strong nuclear staining for the STAT6, and molecular analysis may show this to be also positive. And in cases of malignant SFTs, P53 is very much positive, and the degree of positivity of P53 has been found to correlate with the poorer prognosis of the disease. So, Pleura et al. Have classified the solitary fibrous tumors of the pleura into various stages. In stage 0, it is the pedunculated tumor without any sign of malignancy. And stage 1 is sessile or inverted tumor. Inverted means where the tumor in growth occurs beneath the stalk into the lung parenchyma. So this is a sessile or inverted tumor without any sign of malignancy. Whereas stage 2 is pedunculated tumor with signs of malignancy. 3 is sessile tumor with signs of malignancy. And 4 is multiple synchronous metastatic tumors. So what are the features of the SFTs that are suggestive of malignancy? Because if malignancy is present, then there will be recurrence of the disease even after surgery, and the patient will have an overall poorer prognosis. So we have to identify this prior to treatment. So in clinical, most of the malignant tumors usually they are symptomatic at presentation, and there may be a presence of pleural effusion. And it has been found that usually an inverted fibroma might have a higher chance of malignancy. Similarly, solitary fibrous tumors that arise from the mediastinal, diaphragmatic, or the parietal pleura are found to have more chances of malignancy as compared to those arising from the visceral pleura. Similarly, sessile tumors as compared to the pedunculated, and those with dense fibrous adhesions are found to have increased risk of malignancy. Similarly, in imaging, if the tumor is more than 10 cm with extensive necrosis and hemorrhage, with invasion of chest wall or surrounding structures, and on FDG PET with a LCV of more than 2.5, and heterogeneous high signal intensity and contrast uptake on T2 weighted MRI images are suggestive of imaging. Similarly, in histopathology, the classic inline criteria, that is hypercellular nuclear pleomorphism with more than 4 mitosis per 10 hyper fields and extensive areas of necrosis and hemorrhage are suggestive of malignancy, and there may also be areas of dedifferentiation in large tumors. Similarly, in immunohistology, if there is loss of CD34 expression, if there is the Ki67 proliferation is higher, and if there is a positive staining for S100, P16, and especially P53, these are suggestive of malignancy. So various criteria to assess the risk of malignancy have been identified. The most commonly used is the England et al.'s criteria, but Pleura et al. Have also given their own criteria, and the most recent is the Diebold criteria, which has used the MIB1 or the Ki67 proliferation index to identify the high risk diseases. So coming to treatment, surgical resection is the mainstay of treatment for solitary fibrous tumor, and adequate removal of the entire tumor is essential. And as even lesions that are considered to be benign may harbor malignancy, in some specific areas. And here, although lobectomy is not required if only the lung is only partially involved, we should take a stapled wedge of at least 1 to 2 centimeter margin, as there may be tumor cell inversion of the stalk. And in cases of SFTs of the mediastinal, diaphragmatic, or the parietal pleura, as these have higher potential, we should undergo a wide dissection of the stalk. So basically, in the benign cases, resection with negative margins will lead to complete treatment of the disease, whereas for malignant diseases, we should have some margin, negative margin of 1 to 2 centimeter, as there is a chance of recurrence. So in case of malignant SFT, is there any role of adjuvant treatment? The traditional cytotoxic chemotherapy has been found to have minimal benefit for these tumors, and but the use of VEGFR inhibitors and TKIs, they have shown partial responses, especially the use of broad spectrum TKIs such as sunitinib, sorafenib, or regorafenib. They have shown some benefit, but still these are limited to the preclinical studies, and they have not been verified in the human studies. Also, some case reports have cited the role of external beam radiotherapy. It has been seconded, but again, this is not widely used. What about the prognosis? Benign SFTs with those that have gone complete excision, the patients are cured with surgery alone. Whereas for malignant SFTs, they have shown a wide variability in rates of recurrence from up to 30% and long-term survival also. So this, however we define it, the most important predictor for long-term survival in any type of SFT is the completeness of resection. And even benign SFTs that recur again can undergo multiple sessions of re-resection, but each resection increases the chance of malignancy. So this should be noted, and a wide resection margin should be taken in the re-resection patients. So most patients with recurrent disease, they survive less than 2 to 5 years without any resection. So there have not been any systematic studies for these tumors because these are rare, but many, mostly England and they have published their long, large case series, and this is one review of 223 cases by England et al., where they evaluated these cases over a period of several years, where they divided the 223 cases into 141 benign and 82 malignant cases. And for malignancy, again, their criteria, they created their criteria of high cellularity, mitotic activity, and pleomorphism, hemorrhage, and necrosis. And with this, they found that around 1/3 of the cases were malignant in nature. So this was another case series by Cardillo et al., where they evaluated 110 patients with SFT, and again they found that visceral pleura was the most common site of origin in 95 tumors out of 110. Similarly, most of these cases were benign, whereas around 13% were malignant. However, the overall 10-year survival in all of these patients was 97.5%. And again, they have identified that surgery is the gold standard treatment, as neither radiotherapy or chemotherapy was effective in the treatment of these diseases. Similarly, another large case series of 80 patients by Bodard et al. Also revealed that surgical resection with histological free margin could be accomplished in almost 93% of the cases, and what they found was that again for malignant tumors, the most common factors that were significant were the presence of symptoms, the large diameter of the tumor, presence of fibrous adhesions, and presence of pleural effusion. And again, the Ki-67 index 10% or greater was found to have increased risk of malignancy. Again, these cases had a great 5 or 10 year survival of 90% and 86% respectively. So with this, I come to the end of the solitary fibrous tumor. I'll give a short introduction to the rare primary tumors of pleura that we only rarely see, but we may encounter in our clinical practice. So the first of this is the calcifying fibrous tumor of the pleura, which was first described by the Pinkard et al. And these are slow-growing pseudotumors characterized by presence of abundant ionized collagen with pseudomatous or dystrophic calcification and lymphoplasmacytic infiltrate. And these have no malignant potential and are cured by surgery. Again, there are adenomatoid tumors, which are small nodular pleural lesions, typically found incidentally on imaging or intraoperatively. And they are composed of epithelial cells with mesothelial differentiation present in a fibrostome. And they also have no malignant potential and are curative with surgery. Similarly, sclerosing pneumocytoma or hemangioma are benign epithelial tumors more commonly found in the lungs, but again rarely arise from the pleura, and there are 5 times more common in females than males. And they are typically identified incidentally on imaging as non-cavitating peripheral nodules less than 3 cm diameter, and surgery is curative. Similarly, pleural schwannoma arise from the sheaths surrounding the autonomic nervous fibers, and they are slow-growing tumors, usually present in young adults with slight male predominance. These are very rare tumors with less than 20 case reports, but surgical resection is curative in these tumors also. So in case of malignancy, the overwhelming majority of the malignant lesions are either diffuse malignant mesothelioma or the metastatic lesions involving the pleural surface, or the direct invasion from the adjacent tumors from the lung or chest wall. These metastatic lesions include the melanoma, thymoma, epithelioid sarcomas, and adenocarcinomas from various sites. But today we will be talking about the rare variants, as I'll talk about the malignant mesothelioma in another presentation. So one of them is the desmoplastic small round cell tumor, which usually arise in the abdomen, but rarely have been reported to arise from the pleura. And the tumor is composed of small poorly differentiated cells with malignant appearance. And the classical finding is that there is a translocation of the T1122 translocation, resulting in the EWSR1 WT1 gene fusion. So these have a very aggressive clinical course, and despite all multimodal therapies, the survival is very poor, in the range of a few months to a few years. So the other is the primary pleural thymomas. Mostly pleural thymomas are associated with the thymomas that arise in the thymus gland, but rarely may present in isolation with the normal thymus. And these ectopic thymomas are rarely associated with myasthenic gravis and radiologically appear as diffuse nodular pleural thickening, mimicking malignant mesothelioma. Complete dissection of both the primary tumor and the native thymus is recommended, and adjuvant chemotherapy and radiation is based on the histological grade and stage as per the thymoma.
In my clinical practice, I have operated on 7 or 8 tumors which are totally typically located in the pleura. Out of one patient we did not operate on because that was encasing the subclavian artery vessels. In that patient, I did the partial explant, and the patient had inside the ribs, clavicle, etc. from the mesh. Patient is still surviving, I think 8 or 9 years beyond the reason. I sent the patient to the Multimodal diagnosis. They would do the grafting, etc. because totally encasing the vessels. So they also rejected the patient. They said, no, it's not possible. We advised to the radiation therapy. She received radiation therapy. She is still surviving with the lesion, with the pain, but she is still surviving. Another example is one of the patients who had got the young patient, female lady. She is still surviving, similarly the fibromatosis. She still keeps on coming here in our clinic. I think by now she is about 26, 27 years. She came here for the first time when she was 16 or 15 years of age. I did the surgery, cyst section with the protein was repaired. It was recurred now, she recurred. We did the radiation therapy with the visible huge lump, it's not size of it. She's surviving with the disease. She's married, she has got a child. There are nothing to do. And 10 years beyond the time of the life. So these are the intermediate models of what can happen. Attention problem can be that's also true. So I think overall, we shouldn't miss these kind of tumors. So recently we did one of the solid. Recently, now there have been a private matter. So it's very small size for tumors, so we can do the best and uniform best, the best approach. This is what Nikala the Police. Let's say multiple water remote I think it's the best. It's Nikala, they do this. That's very. This is not so uncommon, though, but just the malignant pleural is totally actually diagnosed by immunohistopathology. Proven malignant mesothelioma mainly after practice for 5 years they tested. They rely on the histopathology exam. They think that this is mesothelioma, but you can simply confirm it without histopathology. Whereas malignant mesothelioma has a department like some performance of the police immunohistopathologically proven 5 years they has a mesothelioma.
त्यो त occupational disease हो सर हामीले lifestyle disease
report गर्छ कि after the let's say this solid to have a tumor, but it's not so uncommon.
Right? When I was in Tata last time, lot of 5 to 6 cases of solid fibrous tumor in 3 months. The rare case, but usually we just very late. So we usually from non-flying. When I was there was not only small tumors of the solitary fibrous. There were huge tumors occupying almost all of the human thorax. In some cases, including the diaphragm, and so urgent resection is the main thing. Wherever possible, we have urgent. So there were 3 or 4 pneumonectomies done for the solitary fibrous tumor itself, and 1 case of complete diaphragmatic resection along with the lobectomy or right lobe lobectomy of solitary fibrous. Never possible section as much as possible, and there are various discussions for the solitary fibrous tumor. Again, they could not operate because of the invasion of the vessels. So some may require the cardiac bypass if they is involving the intestine, because all of things were the other side. So there was the biggest tumors I have seen in the pleura are the solitary fibrous.
We have one case in our ward, so I don't know whether we're trying to operate on again. The best time, because last time we did the Prognostic further. We couldn't enter inside the chest cavity. Both was just weird, there was no space. So now if the patient part agrees, then we will extend the incision to the partial external, like swimming clamps and all the external will continue with this. So we will have the virgin area. But we couldn't find any area where through which we could enter the fluid.
Can you do a thoracoabdominal approach?
No, when you diagnose. What medical use?
Clamshell, I think clamshell is the best approach for most of the because in the clamshell we can look at both the thorax and the
the best option would be that we can visualize the pushed lung. We can find out some virgin areas so which we can enter inside. That could be one of the options. The patient like it.
In those cases also, parietal pleura was mostly not involved. Always on the external pleura or the diaphragm.
On the